Welcome to today's webcast from the Agency for Healthcare Research and Quality about AHRQ's CAHPS program, Improving Response Rates and Representativeness, an overview of Web First and other strategies. My name is Joann Sorra. I'm a Vice President at Westat and the Project Director for the contract that supports AHRQ's CAHPS program, and I'll be the moderator for today's webcast. Next slide. Let's briefly go over a few housekeeping items. First, if you're having any issues with sound coming from your computer audio, you can connect to the webcast audio using your phone by clicking Phone Call to find the dial-in number and meeting ID. Or you can click Call Me to enter your phone number and receive a call back from Zoom. If your computer freezes during the presentations, you can try logging out and logging back in. At any point in today's webcast, you may ask a question through the Q&A icon. We encourage you to share your name or organization or role when you type your question. Speakers will respond to your questions during the Q&A portion that will take place at the end. Please note that the raise hand feature and chat are disabled. You can download presentation slides, view the agenda and speaker bios on our event website at https://events.westat.com/CAHPS. Finally, there's only one Zoom link for the entirety of today's webcast. If you leave at any time, you can rejoin with the same link provided in your email after you registered. Next slide, please. Now I'd like to introduce today's panel. Jonathan Bakdash is a social science analyst for AHRQ's CAHPS and SOPS programs at AHRQ. Julie Brown is a senior survey researcher at the RAND Corporation. Marc Elliott is a senior principal researcher at the RAND Corporation. And Elizabeth Goldstein is a director within the Division of Consumer Assessment and Plan Performance for the Centers for Medicare and Medicaid Services. Next slide. Today's agenda will start with Jonathan Bakdash giving an overview of AHRQ's CAHPS program. Then Julie Brown will present information about trends and survey response rates. Marc Elliott will discuss mode experiments pertaining to the hospital CAHPS survey, as well as the CAHPS Medicare and CAHPS Hospice surveys. And Liz Goldstein will discuss CAHPS surveys at CMS. We will end with a question and answer session at the end. Now, I'd like to hand it off to Jonathan Bakdash from AHRQ.
Thank you, Dr. Sorra. I want to welcome everyone and thank you for joining us today, and welcome to current users of CAHPS as well as new users. Today, I will be giving a brief overview of AHRQ and general information about the CAHPS program. The CAHPS program stands for Consumer Assessment of Healthcare Providers and Systems. Next slide, please. AHRQ is a science-based agency. AHRQ has a number of core competencies. AHRQ is focused on investing in research and evidence to make healthcare safer and improve healthcare quality. This includes creating tools for healthcare professionals that improve patient care, also measuring and collecting data used by healthcare providers and policymakers to evaluate the performance of the U.S. healthcare system. And the general aim of AHRQ is to move science to implementation and to get AHRQ tools and products into the hands of users. So the core competencies include health systems research, practice improvement, and data and analytics. So what AHRQ is not a regulatory agency. AHRQ does not require the use of any of our tools, products, or databases. We encourage use of that, and we encourage submissions to the CAHPS databases for quality improvement and other purposes. And our investment in patient experience is for survey development and research related to that. And also, we host a number of databases for selected CAHPS surveys. Next slide, please. I'd like to define patient experience now. Patient experience is what actually happens to a patient in a healthcare setting or with a health plan, how often something happens. It encompasses this range of interactions the patients have with the healthcare system and providers. And this slide shows some of these elements of patient experience. And these are just some of the examples of elements that get addressed by CAHPS surveys. This is not exhaustive. And I'd also like to point out that patient experience is different from patient satisfaction. Patient experience is really not quite the same thing. Patient satisfaction is how patients feel about their healthcare and expectations, not what actually happened to patients during their healthcare. And it's very common to use these two interchangeably, but I just want to emphasize that they're not necessarily the same thing. Next slide, please. CAHPS surveys are a gold standard for patient experience. And the reasons for this are they capture the patient voice during the development process. It's items that patients have told us are important to them to measure and report. And this is extensive testing with patients to make sure the questions are relevant and understandable. And there's a standardized methodology for this development and validation and revision process for CAHPS surveys and extensive testing and retesting with patients. Next slide, please. And this is to give you a sense of the variety of CAHPS surveys and that these different puzzle pieces cover essentially different areas, whether it's experience with providers, experience with facility-based care, experience with health plans, or condition-specific care. And there are multiple levels of delivery, whether it's doctors, clinics, hospitals, or specific healthcare conditions. And this just gives you a sense of kind of the variety of CAHPS surveys, and there are numerous CAHPS surveys. Next slide, please. And there are also a lot of uses for CAHPS surveys, and this includes quality improvement, public reporting, certification and recognition, value-based purchasing, and health services research. Next slide, please. So today, presenters are going to cover increasing and improving response rates and representativeness with CAHPS surveys. And this is an image here. I just want to point out that there are over 40 publications from 20 years of research from the CAHPS program on survey administration. And today you're going to be getting an overview on effective strategies to improve response rates and representativeness. And this is a very common question: how can response rates be improved? And we hope to provide a summary distilling all of these publications to give you effective strategies. Next, Dr. Brown is going to present on trends on survey response rates. Thank you.
Julie, you're on mute.
Great. Thanks, Jonathan. Hello, everyone. Next slide, please. It's generally acknowledged that survey response rates are declining. In the last 20 years, we see decreases of more than 30 percentage points. The decrease is observed in all modes of data collection, but the effect is greater on public opinion surveys and national household surveys. Surveys related to healthcare, including patient experience surveys, are also effective. Let's look at response rate trends. Next slide, please. We're looking here at historic response rates for 2012 to 2022, so the last 10 years, for some well-known national surveys. The blue line is the current population survey, which is one of the largest and oldest national surveys conducted in the US. The red line is the National Health Interview Survey, which is a key source of information on the health of the civilian population in the US. And the green line is the Medical Expenditure Panel Survey, specifically the household survey of families in the US. The chart displays response rates for the first year of participation. These surveys are conducted using a mix of in-person interviews, phone interviews, and in some cases, self-administration. Across these and similar surveys, the trend since 2012 has been a response rate decrease of about 20 percentage points. 2012 is to the left and over to the right is 2022. Next slide, please. CAHPS is not immune to the trend of declining response rates, but the decline in response rates has not been as great compared to these other national surveys. We're looking at 6 national CAHPS surveys conducted in various modes. While the trend since 2012 is a decrease in response rate, unlike other national surveys, CAHPS response rates have decreased by by less, that is by 15 percentage points or less during that time. Again, 2012 is to the left and 2022 is to the right. Next slide, please. There's no single cause for the decrease in response rates, but here are some of the challenges we find in achieving high survey response rates. Contact rates, or our ability to contact or reach the sampled individual, are historically lower due to things like fewer landline phones, use of technology such as caller ID and call screening, delays in the U.S. postal delivery, and challenges to the quality of available contact information. Many individuals do not trust the organizations that contact surveys, and many of us fear survey attempts as a scam. Survey participants are concerned about their private information and how it is used and secured. The frequency of surveys is a factor, as receiving multiple survey requests over a period of time can lead to what we call respondent fatigue, or respondents being less likely to participate. The length of the survey can be a factor, as shorter surveys tend to result in higher response rates, but more important than length is the clarity of the survey questions. Next slide, please. As a lead-in to what you will hear from Marc and Liz, I want to touch on the role technology plays or can play in promoting or increasing response to surveys. Technology can be a useful tool in promoting awareness of your survey via informational web pages, through use of posters with QR codes to link to information about the survey, and social media postings, all of which can promote the legitimacy and importance of your survey and help to boost response. Technology provides us with new methods to contact patients, such as SMS, short message service, or what we think of as text messaging, email, or survey invitations that are provided via QR codes. It also gives us new modes of survey administration, such as web surveys and surveys via SMS. It is important to use technology that is appropriate for and accessible to your population. And with that, I'll hand it over to Marc.
Thank you very much, Julie. As was mentioned, I'm going to be talking about a series of randomized mode experiments that have been used to gain insight into the effectiveness of various survey modes in increasing both the representativeness and the response rates of CAHPS surveys. And I'm going to be drawing from a number of different CAHPS survey implementations. Next slide, please. The CAHPS Hospital, CAHPS Hospice, and the MA and PDP CAHPS surveys have all recently administered randomized experiments in the hopes of doing this. The HCAHPS and CAHPS Hospice surveys also examined the potential effects of extending the field period from 42 to 49 days, both in a way to more easily fit an additional web-first mode protocol, but also examining the potential benefit to those outright. And then the CAHPS Hospice survey also tested the use of a pre-notification letter. Next slide, please. So I'll start with some background on the HCAHPS survey. This work was motivated not just by interest in increasing response rates overall, but an interest in ensuring high response rates for all groups of patients, including those that have historically had lower response rates. That would include adults who are Asian American, Native Hawaiian, Pacific Islander, Black, Hispanic, and also younger patients. If you can improve response rates, particularly for these low response rates groups, that has a number of benefits. It first of all ensures that the HCAHPS survey fully captures the experiences of all patients, and it can support efforts to measure and improve health equity, and also there are benefits. There are other benefits in that if you increase the response rates for the lower response rate groups, you automatically increase the representativeness of the survey as a whole. Next, please. So there are two approaches that we examine in the context of AHCAHPS. One of them involved sequential multimode approaches, and the other involved longer data collection periods. So when we talk about sequential multimode approaches, what we mean by that is you first give people the option to reply in one survey mode, and then among those who don't respond, you follow up in another, and then sometimes even with a third. That approach is, first of all, there's clear evidence it's superior to giving people a simultaneous choice, which seems to result in people being paralyzed in which to use. But by following these one at a time, it is mindful of the fact that different people have preferences for responding by different modes. Some people love to respond to a mail survey. Others never will. Same can be true of web-based approaches and also telephone approaches. And when you do this, you can maximize both the appeal to the respondent and also the response rate and representative. And what I'm going to describe, we're going to evaluate 1 3-mode protocol, 3 2-mode protocols, and 2 single-mode protocols. We also, as I mentioned, look at the possibility of adding 1 week to the data collection period. One reason to do this is if you have these multi-stage protocols, you can really get the full benefit of them if you allow a little bit more time. But also, even with an existing protocol, mail isn't always as quick as it is. It's not always easy to get people to complete a phone survey in a given period of time. So extra time can actually increase response rates even for existing modes. And then moreover, the people who you get at the very end of a survey protocol are actually typically underrepresented groups, harder to reach groups. And so there can be value in terms of representativeness in going just a little bit longer. So in particular, we look at 49 days versus 42 days here. Next slide, please. So I'll briefly describe the structure of the 2021 AHCAHPS mode experiment. There were 47 participating hospitals that were broadly representative of hospitals that participate in AHCAHPS. We got data. We tried to reach 36,000 patients who were discharged during a 6-month period. In 2021, we applied the standard AHCAHPS criteria. Of the participating hospitals, they were able to supply email addresses from patients for 63% of the cases. And then within each hospital, patients were randomized to one of 6 different mode protocols. We limited our survey administration to English. And so in many ways, we think the benefits that we describe here are likely to be greater when implemented in a variety of languages. We did this with a 49-day field period, but we know when all the data came in, and so we can use that to compare the first 42 days to the last week. One other thing I'll comment on briefly is not everything that we're going to examine here is something that we knew about people before we administered the survey. For example, we weren't aware of people's race and ethnicity until they responded to the survey. But a nice feature of a randomized experiment is you can tell, even if you don't know the race and ethnicity of non-respondents, you can tell which protocols increase response rates by race and ethnicity, for example, because randomization means that the people to whom the survey was administered were on average similar across all the different mode protocols. Next slide, please. Here I'm just going to outline how the 6 different protocols were structured. So the columns here are the 6 different mode protocols. The ones with yellow highlighting are the 3 that are new and that start with a web component. And then you can see in the rows the day on which each of these occur. The mail-only protocol involves 2 mailings. The telephone protocol involves phone calls throughout the whole data collection period. The mixed mode protocol starts with a single mailing, and then there's telephone follow-up. The web mail mode involves an email-based initial invitation, then a second one, and then a third one. After that, you go to the mail phase, and there are 2 mailings. In the web phone, there are 3 email outreaches, and then you go into the telephone phase. And then in the web mail phone, the 3 mode protocol, there are 2 email survey invitations. Then there's a single mailing, and then you enter phone follow-up. One feature here is for the 37% of patients who didn't supply email addresses. If they were randomized to one of these web-first protocols, then they essentially didn't start the protocol until the first non-email phase began. So, for example, somebody randomized to webmail who didn't supply an email address to their hospital would just start on day 8 with the mailing of that first survey, so they'd be synchronized with everybody else in that protocol. Next slide, please. So here are the overall results on response rates from this mode experiment. So the current HCAHPS modes, mail only, phone only, and mail phone, have response rates that varied from 22 to 31%. And then the new protocols, the web first ones, have response rates that varied between 29 and 36%. The thing you'll notice if you stare at these is that the single mode protocols have the lowest response rates, 22, 23%. The 2 mode protocols, whether they involve web or not, are in the middle. So mail phone, web mail, web phone are all in the 29 to 31% range. And then the 3 mode protocol, web mail phone, does the best at 36%. If you compare a web first mode to its counterpart, you can see big gains in response rates in every case. So webmail adds 7 points to mail only. Web phone adds 7 points to phone only. Webmail phone adds 5 points to the existing mixed mode protocol. Next slide, please. Now that's kind of pooling everybody, and as you might imagine, the web first modes are most effective for people who supply email addresses. And so here we just take that last slide and we break it down into people in the middle column who didn't supply an email address and people in the rightmost column who did supply an email address. Let's focus on that rightmost column because essentially if you could get 100% email addresses from people, then this is more or less what you would expect to get. And you can see now the web first protocols for people with an email address are getting 34, 37, and 40% response rates, which are markedly higher than what you see with the current protocols, particularly the mail only and phone only protocols that are the ones that are currently most often used. Next slide, please. So the potential to greatly increase response rates, and note that in many cases you're talking about response rates that are half again as large or even 2/3 again as large as you get with mail only or phone only. That's exciting enough, but particularly exciting to us is the fact that the benefits specifically accrue to some of the groups with lower response rates currently at a much higher rate. So webmail phone had the highest yield in terms of responses from racial and ethnic minority groups in 3 of 5 cases, and the second highest for another. And in particular, turning to the third bullet, mail only turns out to have the lowest performance for Black, Hispanic, and multiracial patients, whereas phone only has the worst performance overall for white patients. Neither of those works, that they tie for worst for Asian American and HPI patients. And if you look at the specific gains that you get for these multi-mode approaches that involve web, the gains that you get for each of these racial and ethnic groups are 2 to 3 times as large as the gains you get for white patients. And so you get huge, although it's not possible to calculate the exact response rate by race and ethnicity, it's clear that the response rates for each of those racial and ethnic groups increase by very large amounts. Next slide. There's also improvements in representativeness by age. The webmail phone approach had the highest yield for almost all age groups. And in particular, and so pretty much that 3-mode protocol does just remarkably well for more or less every group. But if one were to go with a 2-mode protocol, then the web phone approach works particularly well for adults ages 18 to 64. The webmail works quite well for 65 to 84, and then on the negative side, on the flip side, mail only is the lowest performing mode for adults under 55, and phone only is the worst performing mode for adults 55 and older. Next slide, please. So when we looked at this by service line, when we looked at this by service line, then we found that again, webmail phone was pretty much always the best approach. But of the 2-mode protocols, webmail did really well for surgical patients. Web phone did really well for maternity patients, and mail phone did especially well for medical patients. Mail only had the worst performance for maternity patients, consistent with its poor performance for younger patients, and phone only had the lowest performance for the medical and surgical patients, consistent with its worst performance for older patients. Next slide. Here's a summary of for each of these characteristics that I've talked about: age, race and ethnicity, service line, and sex, as to what tended to be the worst and best performing modes. As you can see, the worst performing modes are almost all single mode protocols, with mail only doing particularly poorly with younger and more diverse populations, and phone only doing least well with older and predominantly white populations. And then in the second column, you can see webmail phone does remarkably well, and many of the web first 2-mode protocols do quite well also. Next slide. Briefly, when we looked at the effect of adding an extra week to data collection, we found that an average of 3 percentage points came in the last week, and that's not just true in the web first modes. That was true across the board. So there's a lot to be gained for waiting just another week. And the other thing that's really interesting is that the respondents in the last week were in a number of ways more diverse than those who came earlier. Racial and ethnic minority respondents were more than half of people who responded in the last week, compared to 40% of those who responded in the first 6 weeks. There were also increases in people whose preferred language at home was a language other than English, even though this was an English-only protocol. So presumably those gains would be greater still in an implementation in multiple languages. And then also we just wanted to note that it's important to hear from late responders, because often the hardest to reach people are the ones who do have the worst and most challenging experiences that we need to hear from. Next slide, please. So just to summarize, these web-first multi-mode protocols greatly increase response rates, and they especially do so from some of the groups that were currently that currently have the lowest response rates. Multi-mode approaches, the best approach for a given hospital will vary and dependent on its population. And I hope some of the summary information here helps clarify which modes are particularly beneficial for which groups. I'm going to segue now to the second section that I'm presenting. Next slide, please. Here I'm going to briefly describe some similar experiments from other CAHPS implementations, and the MAPD CAHPS survey, which is administered to people with Medicare, asking about their experiences with their Medicare Advantage or prescription drug plan survey. There was a protocol put in place where we compared a three-phase web, mail, phone approach, very much like what I described in the context of AHRQ, and we contrasted it with what's the current standard protocol, or sorry, what was the prior standard protocol, since this web, mail, phone approach is now the new standard here. And you can see that in this approach, we retained the two mailings and phone follow-up. And in addition to having email-based outreach to a web survey, we also included a pre-notification letter with a URL and PIN codes, providing an opportunity even for those who hadn't supplied an email address to participate. At the time of this randomized experiment, a third of members had supplied email addresses to their plans. We expect that this will increase greatly, and so that the benefits observed here are likely very conservative. Next slide, please. So in this implementation, likely due to the more limited email address availability, we didn't see a statistically significant increase in response rates overall, but among people who had email addresses supplied, we saw more than a 4 percentage point increase in response rate. And it's also the case that implementing this web-first approach resulted in a reduction in the number of surveys that needed to be mailed out, because we had already heard from people via email, via web. And so again, clear evidence of potential cost savings, as well as increases in response rates that are likely conservative to what we would expect in a fuller implementation. Next slide, please. So as I mentioned briefly, one of the potential advantages here, I focused so far on response rate and representativeness, but there's also potentially a cost savings. You'll notice that in each of these approaches, we start with the least expensive mode and we progress towards more expensive mode. And so there's the potential to create savings through substitution. And in particular, we do find evidence that even when the response rate, that beyond the absolute increases in response rate, you get substitution of more expensive, of less expensive, more expensive modes. And in some cases you can and so that that's another potential savings there. And next slide, please. I'll end with this section with a discussion of a randomized experiment from the CAHPS Hospice survey. So this randomized experiment involved randomizing. This is a survey which is administered to caregivers of decedents who received hospice care. In this protocol, there were 5 different arms. Not all of them are directly relevant to what we're discussing here. In particular, I'll be focusing on a web mail approach and its contrast to the mail-only approach, which is the most used approach for the CAHPS hospice survey currently. Next slide, please.
If you can wrap up in a few minutes, that'd be great.
Will do. Next slide, please. So 56 large participating hospitals were involved in this. Pre-notification letters were sent ahead of time, and as an additional experiment that was overlaid to half of the people, an additional experiment that was overlaid on top of the mode experiment. The webmail approach that we're looking at involved an initial email inviting respondents to participate by web. And then there were email reminders and 2 mailings after that. Next slide, please. In this case, if you compare the 2 relevant arms, you can see that adding the web component added almost added 4.6 percentage points to the existing mail only response rate, and that's across everyone. Next slide, please. If you focus just among people who had email addresses, however, you see that adding this web component increased the response rate by 13 percentage points from 35% to almost 50%. So again, in a situation where the email address availability was high, you can see there's tremendous potential to increase response rates by adding a web component up front. Next slide, please. Next slide, please. Thank you. So to briefly summarize for the CAHPS hospice survey, we found that the pre-notification letter, independently of everything else, added about 2.5 percentage points. Extending the field period added about 2.5 percentage points to response rate, which is fairly similar to what we saw in the other survey, and really big increases in this case from adding a web component. Next slide, please. And so to briefly summarize across the 3 sets of surveys where we examined randomized experiments, adding a web-first component to an existing approach adds between 4 and 14 percentage points to those with email addresses. These gains disproportionately fall on groups that have lower response rates currently. Greater collection of email addresses means bigger benefits here. There's potential for cost savings. Also like to note that adding a week of field time adds 2.5 to 3 points to response rates. Pre-notification letters help. And if you sort of take these factors together, you can see that there's a lot of potential to counter some of the declines in response rate that Julie notes have affected CAHPS surveys to a lesser extent than surveys in general. And there's also real potential to both save money and increase representativeness. Passing this now to Liz.
Thank you. Next slide. So before I go into ways that CMS is considering to increase response rates, I just want to give you a little background about the CMS CAHPS surveys. CMS publicly reports the data from the CAHPS surveys on Medicare.gov, and this is really to help inform decisions that our beneficiaries or their family members are making when they choose providers and plans. Generally, the CAHPS information is, when you talk to beneficiaries, is really a key piece of information for them. They're really interested in what others think about various providers and plans. Many of the CAHPS surveys also impact payments to providers and plans. This could be through an annual payment update or value-based purchasing. Next slide. So CMS is considering a variety of different ways to help increase response rates. In some of these cases, it's recommendations for providers that may contract with a survey vendor about things that they can do. One of the things that we've been looking at is for some of our surveys, shortening the length of the survey. We've been testing across most of our surveys, adding the web mode of data collection. We encourage providers in settings where there's a choice of survey administration mode. We really encourage providers to think about, what mode would work the best for your population. We also have been doing testing on cover letters, CADI scripts, promotional materials, really to help encourage potential respondents, to fill out the surveys. The other piece that, we try to work with providers and plans with is having the survey offered in the preferred language of the sampled member. Next slide. So in a number of settings, we've been testing shorter versions of the CAHPS surveys. And this is, as Julie said, shorter surveys are better and it helps increase response rates. So I'm not going to go into detail here, but here are some examples of settings where we have been testing a shorter version of these surveys. Any changes to any of these surveys has to go through the rulemaking process. So although we've been doing testing in all these settings, there will not be changes until it goes through the rulemaking process. Next slide. As Marc has been talking about, the web mode of survey administration, here are some examples of settings where we either have the web mode of data collection, for example, the outpatient ambulatory surgery CAHPS survey. The web mode is already available. We're adding it to the Medicare Advantage and Prescription Drug Plan survey this year, and hospital CAHPS, it's coming in 2025. There are other settings where we have done testing. And again, in some of these settings, it maybe we're analyzing data or it has to go through the rulemaking process before it's implemented. One thing I just wanted to note on this slide, it's really critical if you're doing the web mode of data collection is to try to get email addresses of your patients or of your members, because having more email addresses will make the web mode, more beneficial in terms of increasing response rates. We get a lot of questions at CMS, and you may see from, Marc's presentation, why we're not testing or implementing the web-only mode. So we still see that not everyone has access to the internet or the ability to complete the web mode. And we see big differences in internet access by age, by education, by race, ethnicity. So all the modes at this point that we're implementing is web combined, with mail or combined with phone or combined with mail and phone. So at this point, that ensures that everyone has the ability to respond to the survey. That's not to say as things change over time and internet access, continues to increase, this could change in the future. Next slide. So this is just an example of response rates by race ethnicity. This example is for our ICH CAHPS survey, but you can look at this for any survey. And so what we've been trying to encourage in all the various settings where a provider or facility can choose the mode of data collection from a set of approved modes, we're asking that you pay attention to response rates across different modes and look at your population. So for example, if a facility has a large Native Hawaiian or other Pacific Islander population, in this example, you can see response rates are significantly higher for mixed mode, and you probably want to use mixed mode if you have a large Native Hawaiian population. So this is something you should take into consideration and think about when choosing what mode to use. Next slide. So pre-notification and cover letters. We conducted research with Marketing for Change. It's one of the CMS contractors, really on ways to help improve survey letters, cover letters, envelopes, all of this to try to engage Medicare beneficiaries or potential respondents so they will fill out a survey. Next slide. So on this slide, I listed some of the things in our testing that we found worked well and things that didn't work well in cover letters. And I'm just gonna point out a few of them, and you can look at some of this at your leisure. One is personalized letters, really include the first name, the last name, the name of the plan or facility. That was really important. It was also important to have language about that your voice is important, and that includes describing why the results are important and how they're going to be used. What some of the things that didn't work in the letters is sometimes in a letter, it'll include information that, you were randomly selected or has information about the IDs you may see on a survey. When we talk to potential respondents for these surveys, they said that really doesn't matter to them. That's something really more that a researcher would care about versus, maybe an 80-year-old. They really don't care that they were randomly selected. They also didn't like language, for example, that this is your last chance to respond or please respond by a certain date. And that was really, from their perspective, they think their feedback is important at any time. So it's kind of off-putting to say, this is your last chance to give us information about your experiences, or you need to do it by a certain time. The other thing that we saw in terms of the envelopes is not to include information on the envelope showing that it was a survey. In some cases, then they wouldn't even open the envelope or reply by on the envelope. That's again similar to the other feedback in the letter. They feel like their feedback should be important at any point. Next slide.
And Liz, if you could wrap up in the next minute or two, that would be great.
Okay, so the next testing we did was on CADI scripts or the telephone scripts, as well as looking at caller IDs and what should show on the caller IDs. Next slide. So for the caller ID recommendations, some of the things that came up is always display a phone number, use a local number if possible. Avoid phone numbers that could be perceived as spam. Avoid using like the word survey on the caller ID, and use numbers where possible where someone could call it back and validate that it's a real, phone number. Next slide. Some of the recommendations for the CADI scripts, so these are the introductory scripts for telephone interviews, was shorten them, if possible, really just include essential information to establish the relevancy of the survey, legitimacy, purpose, and privacy. Include a purpose statement in each that really conveys, what the direct personal benefit would be from completing the survey. Similar to the cover letter, testing personalization is very important. And it's really important that the interviewers are trained, to promote a positive interview experience. So those are some of the things for the CADI script. Next slide. For promotional material, this is material that your provider or plan can use to encourage their patients or their enrollees to fill out these surveys. I just want to note for all of our surveys, if you use promotional material, it really needs to be provided to everyone. You can't pick and choose, who to provide it to. On the next slide is an example of a poster for a in-center hemodialysis facility. And it's really trying to promote, the importance of giving feedback. Why is it important? What to do if they have questions about the survey. So this is, their survey, the name of the survey vendor that's working, with them. So here's just an example. The next slide. This is about language preference, and CMS is very committed to making translations of the CAHPS surveys available for use in CMS programs. Currently, for our surveys, there are a variety of translations. And when someone expresses a need for additional translations, please just let us know, and we will, add to the translations over time. So we really encourage plans and providers to collect information about preferred language, so the survey can be given in that preferred language. And this is another factor that can help increase response rates. So that's it for my part of the presentation. So I'm going to turn it back over to Joann.
Thanks, everyone. Now we're going to shift to the Q&A portion of our webcast. As a reminder, you may ask a question through the Q&A feature, and please enter your questions now. If you joined late, a replay of today's webcast will be made available on the AHRQ CAHPS website. So let's jump right into a couple of questions that are similar in nature about the scores of CAHPS surveys based on mode. So a couple of questions here from Marc. Did you see differences in scores by mode? For example, do patients rate their experience lower in the mail-only mode versus web first? And, were web modes more or less favorable in terms of scores than mail? So any response about that, Marc?
Sure. So one of the purposes of these mode experiments is to develop mode adjustments that ensure that any differences in responses are fully accounted for in the scores that are used. So there have always been some differences in responses between mail and phone, for example. Broadly speaking, we find that most of those differences appear to be related to visual versus auditory presentations. And so responses to web are very similar to responses to mail, whereas responses to phone are a little different from those. But the key thing is that in HCAHPS, for example, there's no advantage or disadvantage to scores when a hospital chooses one mode versus another, because adjustments are applied that exactly counteract those differences in how people respond, which we measure through those randomized experiments.
Okay, thank you. For the web first survey mode, for patients without email addresses, how were the participants invited to complete the web survey? Was it a notification letter with a printed website URL or a QR code?
So in the case of, so in some of the implementations that we described, there was an invitation with a URL. And in other implementations that we described, there wasn't such an opportunity, and people without email addresses just went to the next phase of the process.
Okay, and do you have a recommendation for how that should be done for those who don't have email to get them to web?
I might defer to Julie on that.
Sure. Joann, could you repeat that question for me, please?
Is there, since in the experiments, those without email addresses were asked to complete the web survey in different ways, sometimes through the notification letter, but other times just going through the next phase. Do you recommend that a notification letter be sent when inviting non-email patients to complete the web survey?
Great question. So as CMS rolls web out across their different programs, they are including paper-based invitations, that is letters, for those who don't have an email address.
Okay, great.
And I'll add maybe one more thing. All that said, as Liz emphasized, and and I noted as well, collecting the email addresses is probably the most important and most effective component in ensuring responses by web. Even though adding that other route will also help, but it really, to get the full benefit, it is really critical to obtain those email addresses.
Okay, great. Next question might be for Marc and or Julie. Does the order of the protocol matter? So does mail go first, phone, web? Does it matter which of these different modes you start with?
I'll answer initially. So in all these approaches where there's been more than one, we've sequenced it in a particular way. We've always put web first when it's involved, and we've always put phone last when it's involved. And some of that is motivated by cost. And in addition, at least with web, that's sort of an instantaneous receipt. And so it's also kind of really convenient in terms of protocol timing to have that up front. So our recommendations in general would be the orders that we've used here, the web first when it's involved, the phone last when it's involved.
Okay.
I agree.
Okay, great. And then there's a question about cost effectiveness. Like, is there a value add in terms of cost to add these different modes? Is it a good investment to offer, if you're currently offering a single mode, to offer two modes or three?
I'll make an initial comment, and others may have comments as well. So if adding a 2 or 3 mode approach, as you can see, in some cases can almost double response rates, and in some cases, and for some groups in particular, it will double response rates. And so even if you were just looking at cost per case, while it's hard to speculate about any given organization or vendor's cost structure, even if you're looking at cost per case, in some instances, the benefits might reach cost effectiveness by that criterion alone. But I would argue that getting hard to reach cases is sort of pushes even beyond a cost per case consideration, and that hearing from everybody and hearing from groups that are traditionally underrepresented by some approaches can really pay for what might be in some cases an additional expense.
And Julie, anything to add to that?
Nothing for me. I agree. I think it's important to assure that you hear the patient voice, and multiple modes is the best way to do that.
Okay, well, we are now at the top of the hour. If we can go to the next slide. I want to thank the speakers for all of this information that's been provided. If you want to sign up for CAHPS updates, you can go to the AHRQ website in the upper right-hand corner and choose the email updates for CAHPS. Next slide. And if you have any further questions or comments, you can email caps1@westat.com or call 1-800-492-9261. And the CAHPS website is www.ahrq.gov/CAHPS. And then the final slide, thank you for attending. A brief evaluation will pop up, and we please ask you to take a moment to provide your feedback. So thanks for joining us. This concludes today's presentation.